Good afternoon, everyone. Welcome to today's Yetenaweg webinar. So today's webinar is titled Epidemiological Study Designs with LIDIYA. So I'll be giving a full introduction about our guest speaker in a moment. Before that, let me give you a brief introduction about Yetenaweg and what we do. So Yetenaweg is a digital platform. It's registered in the US as a nonprofit organization. Currently has 150 and above active volunteers across different countries. You can see our enthusiastic volunteers in this picture. So what we do is divided across 4 major areas, namely health promotion, community engagement, mentorship and skill sharing, and medical education. So on the medical education part, the continuous medical education team prepares bi-monthly webinars across various important public health and medical topics so that clinicians and the medical community can continuously update their knowledge. And we have the health promotion project, in which we have Clubhouse live discussions, posting of health articles, free online webinars, and direct social media engagements. Also, these webinars will be uploaded on our YouTube on our YouTube platform so that people can access them. Here you can see the website where useful health articles are posted. This is the podcast. So the second important area is mentorship. So Yetenaweg family believes in capacitating young medical students, upcoming medical students. So we have a one-to-one personal mentorship where we will pair medical student with an expert so that they can learn various skills. The third is research projects, which is actually today's major theme. So Yetenaweg, in collaboration with ROHA, launched the research fellowship, as you know, and the research fellowship, the research and QI fellowship was a very robust program where around 4 medical professionals got the opportunity to secure grants for their research. So this is one of the main themes of today's presentation as well. And we have the article writing competition, in which we give young medical students the chance to write medical articles. Then there are the Clubhouse sessions, the health advocacy. So we engage in different community programs, volunteerism programs, like the disability inclusion in healthcare, cancer care Ethiopia, and mental health awareness programs. Then the CME, I've already said about it. You can see the pictures. So we prepared a health and art exhibition last time, where there was a fun program where it blended health and art. So here you can see the pictures. Here you can see the Yetenaweg vibrant family. That's all about Yetenaweg. So I will now introduce today's guest speaker, Dr. LIDIYA. So LIDIYA HAILE is a technical analyst at Imperial College London, where she works on projects assessing the impact of malaria vaccination on disease burden in sub-Saharan Africa. Prior to this role, she was post-bachelor fellow at the Institute for Health Metrics and Evaluation, where she modeled the global burden of hearing loss, respiratory disorders, and other non-communicable diseases for the global burden of disease study. She holds a bachelor's degree in public health from Brown University and an MPH in health metrics and evaluation from the University of Washington. She has been published in Think Global Health, Ear and Hearing, and The Lancet, among other respected journals. Without further ado, LIDIYA, the floor is yours. Thank you.
Hello, thank you for the introduction. I will share my screen, and I think that we will get started with the presentation. Great. And if there are any questions at any time, feel free to interrupt me. Yeah, my hope is that this can be interactive, and mostly that this information the presentation can be tailored to your needs. So I will begin. It's been so lovely to be a member of Yetenaweg as a volunteer, and I chose to give this presentation today on a basic overview of epidemiological study designs. So before we get into that, again, I'll just briefly introduce myself. So this is me. Again, I'm a technical analyst at Imperial College. My background is primarily in public health, and for the past 5 years, I have been working in the field of kind of epidemiology, data science, specifically disease modeling, for a few years on chronic conditions, as mentioned, and now working on malaria transmission model at Imperial College. And yeah, the reason why I share my background is in part so you can get to know me a little bit before we begin, but also with the hope that you can understand where I'm coming from, and also in that, in many ways, I'm a peer to you all. And yeah, if anybody has questions after this meeting, I would love to connect with you all further. So my email is here, and I'm sure that these slides will be shared afterward. So now that I've introduced myself, we will get into epidemiology. So I understand that we have a range of professionals in the audience, including clinicians and public health professionals, but I'll just start with the basics. So epidemiology is essentially a study of both the distribution and the determinants of disease. And obviously, we're interested in those factors because the better we can understand how disease spreads and what factors cause it, what factors prevent it, the better we're able to control health issues at the population level and generally improve health status. So that's the foundation of epidemiology. And then continuing on, a basic assumption of this field is that human disease does not occur at random. There are factors that can impact the diseases that we develop and what can disable us, what can kill us. And so identifying these factors can be useful for prevention activities, and also in the development of health interventions. So again, just really foundational metrics of epidemiology that we use frequently include prevalence, which is a measure of the number of individuals in a population who have a disease, typically more relevant for chronic conditions like back pain, like headaches, conditions that are sort of intermittent or longer term in duration. Incidence is a metric of new cases in a population divided by time at risk. Typically, that's the metric that we use when we're dealing with infectious diseases that are, quick to acquire and also perhaps sometimes quick to remit or have higher mortality rates. And then there are many other metrics of disease that we're interested in, including things like a mortality rate, the number of individuals who die from a disease in a population. And then if you go downstream for other large-scale epi projects like the global burden of disease, you have metrics that incorporate years lived with disability, including the disability adjusted life year. So there are many ways that we can measure how somebody is impacted by disease, and they're all relevant in this field. And then again, I'm sure many of you have seen this visual before. You can describe many of the basic epidemiological metrics. You can analogize them with this sink where incidence can be akin to water flowing through a faucet, so new cases coming into the sink. Prevalence is like the water that's contained in the sink, so the number of people who presently have that disease. And then individuals can either remit, or be cured of a disease in some cases, or they may die either due to that disease or due to something else. And that can be analogized by this kind of downward drain of individuals flowing out of the sink. So now that we've gotten through like the basics of epidemiology, we'll get into study design. I'll pause while I'm here and see if there are any questions so far, anything that comes to mind. I'm not able to see the chat, so if anything comes up, please let me know. Okay.
Yeah, Juno, please proceed.
Great. So when we're talking about epidemiology research, we are generally interested in a health problem, a disease in a population. Say we're interested in, I don't know, like asthma in Addis, or in cardiovascular disease in the state of California. While we may be interested in this large population, in most cases, we don't have the tools or the capacity to directly assess the health status of every individual in that population. So one of the basic tenets of research is such that you sample, so you create a subset of that population that is smaller in number, easier to assess based off of the budget or logistical constraints of your study. And ideally, that sample should be representative of your population of interest. So you sample from the population, you assess your participants, and then afterwards, once the study is conducted, you can make inference from your sample out to the population. And different study designs sample individuals differently. And it's really important for us to understand this critically when engaging with other people's research. And also as we learn how to interpret the results of different studies and how to perhaps conduct our own. So going into the large grouping categories for different types of study designs, first we have a formative qualitative study. So a qualitative study in this case would be something in which the primary form of data collected is narrative-based. So words coming from interviews with individuals that are then just analyzed, perhaps coded up, or key themes are taken from interviews conducted with people. And you may want to do a formative qualitative study if you're interested in a particular health condition, but don't really know what factor to dig into further with an analytic method, like what exposures may be relevant with this disease, what determinants of health are relevant with that condition. And so here on the right-hand side, I'm showing you an abstract from a formative qualitative study conducted by this research group in which about 25 participants who were HIV patients were interviewed with relation to the factors that were impeding their adherence to antiretroviral therapy. And so those interviews were all conducted, they were analyzed and reported out upon. And so this is an example of a formative qualitative study that you may do to initially investigate an issue on a small scale. So continuing, and also I should mention all of the links for the studies that I'm referencing today will be in the slides and can be dug up after the fact. Another kind of study design at the general level is a descriptive study. And we can describe a descriptive study as essentially just like a straightforward reporting of the facts or the metrics associated with a particular condition. So the distribution of a disease, perhaps how prevalence or incidence is changing over time, who is most affected, between different genders and things along these lines. So it's quite straightforward. It's descriptive. You're describing the situation. You're not necessarily manipulating anything about it. And the example that I'm showing on the right-hand side is data on obesity in the United States, which was taken from NHANES, which is a large-scale population representative survey from the US. And yes, it's just reporting on obesity in the sample. So that is a descriptive study. And now we'll go into analytic studies. We'll probably spend most of our time in this presentation discussing these. So analytic studies deal specifically with the determinants of disease. So why is somebody developing a condition? What is the mechanism for that development? And it's a great way to test a hypothesis about the relationship between an exposure, like, for example, smoking, and a health outcome, for example, lung cancer, which we know that smoking is associated with and can cause the development of lung cancer. And so, yeah, analytic studies can be a great way to assess the relationship between exposure and health outcome. And so there are two different kinds of analytic studies. So there are observational studies in which the researcher just observes the health outcome in a sample as well as the exposure. But the researcher does not specifically interfere with exposure at all. It doesn't really interfere with the subject's lives or experiences. And with an experimental study, that's a little bit different. The researcher will actively manipulate and choose perhaps one group of people to receive an intervention or to be exposed to one thing, and another group of people who will not be. So that level of interference is the difference between an observational study and an experimental study. And so there are many different kinds of observational studies, which we'll get into in more detail in the presentation. So these include a cross-sectional study, a cohort study, and a case control study. And then this is just like the high-level overview of the different study designs that we will cover in this presentation. So like I mentioned, qualitative studies, descriptive and analytic studies. Analytic studies can be either observational or experimental, and we'll go through these different kinds. So first, we will discuss a case series or a case report. I'm sure, as there are many clinicians in the audience, that you're all familiar with a case report or a case series, but essentially a case report is a description of the clinical course of disease for one individual. They're often published in medical journals, and they can be useful in just understanding different courses of disease in different individuals. If a disease is particularly novel, it can be useful to conduct this sort of study or to carry out this sort of report to share information with different clinicians on how to treat this condition. It can be useful in investigating different treatment pathways. But again, it's descriptive. It's just one person or maybe a small number of individuals who've been treated for this condition. Yes, so I have an example of a case report that is quite famous on this slide. And this is the case report in the New England Journal of Medicine of the first case of COVID-19 in the US. So it's just a paper that describes this patient's symptoms, how they were treated, and yeah, how they remitted, and other implications, which was very important early on in the pandemic in terms of understanding how people were responding to this virus. Now we will move on to a cohort study. So a cohort study is a study design in which you take a sample, a group of individuals, and you follow them longitudinally, meaning over time, for a specific health outcome. So you can either follow these individuals prospectively into the future, or retrospectively since a particular event. And it's very common for cohort studies to take place over many years, many decades, even with routine follow-up in that sample over that period of time. And cohort studies can be very useful for examining very common conditions. So diseases that are highly prevalent that may just naturally arise in a sample of any size anyway. They can be useful in assessing many different outcomes for the same exposure, and can also help us understand the relationship between exposure and health outcome. So an example that I've shown here is a cohort study of BCG vaccination and tuberculosis in Tunisia, where they took these individuals in this part of Tunisia, took and kind of assessed the rate of TB incidence in either group based off of their vaccination status. So a cohort study is very similar to an experimental study where you may manually assign somebody to different exposure groups, but you just don't assign that, and you follow individuals over this long period of time and kind of assess amongst those exposed to a certain exposure and those unexposed, the rates of disease acquisition in these groups. And then you compare those rates between exposed and unexposed group to assess the association between exposure and health outcome. I'll just stop for a moment. Are there any questions for the portion that I've covered so far?
No questions so far, but we will have a Q&A session by the end.
Okay, great. Then I will just continue on.
Yes, please do.
So to reiterate, a prospective study is such that you take a group of individuals and then you follow them out into the future. And so here in this example, you have a case where you have a group of people, maybe they're vaccinated, and then after that vaccination period, flu season comes where they may develop a health outcome. They'll either develop flu or they won't. So a prospective study is such that we start following those individuals before both the vaccination and the health outcome develops. So you're just following them over that entire period of time, and it could be several years. A retrospective study is one where we instead we are following them, I guess, after the flu season has occurred, and we're looking backward to see who developed this health outcome, also who was vaccinated before this health outcome. And so now I have a list of pros and cons. We won't need to get into this entire list, but essentially the high level is that a cohort study can be really great for assessing the risk of disease because you know that your exposure of interest will precede your disease, the disease that you're interested in studying. And you can also investigate multiple outcomes, but you also have certain limitations to this study design. They're often very expensive because you're taking individuals over a long period of time and you're following up routinely. And that requires a lot of resources, administrative and logistical. And also, individuals may just leave your study lost to follow up is a big issue with these kinds of studies. And they're really best suited for very prevalent diseases that don't have a long latent period to develop. Great. So now we've described a cohort study, and we will move on to a case control study, which is also another observational analytic study where instead of taking individuals and just following them to see if they develop a health outcome, we sample from our population based on the health outcome that we want to study. So say we're interested in asthma, we'll sample maybe a few hundred people from our population who we know have asthma. And in addition, we'll sample a group of controls who don't have asthma. And we will look at both of those groups. They ideally should be comparable. There shouldn't be like a fundamental characteristic difference between these groups. And then we will look and see the difference in exposures between these groups. And we will assess the proportion of, say, asthma cases who were exposed to our exposure of interest, as well as the proportion of controls who were exposed to the exposure of interest. So that is a case control study. An example that I have here, the link is also on this slide, is a case control study of cholera in Addis Ababa, where in this case, the investigators took they took a group of cholera cases in Addis, and then they also took a group of controls who were comparable to those cholera cases. And then they looked at both groups. They collected demographic data on their exposures to assess what differences between those groups could be associated with having cholera or developing cholera. And so the benefit of a case control study is this study design can be very useful for examining a very rare outcome, in that you sample from your population specifically based off of that health outcome. And you perhaps could assess many different risk factors for the same health outcome. And it can be much quicker and more efficient than a cohort study. And then, like I described earlier, ideally you would randomly sample all of the cases for this health outcome, such that they're representative of your larger population. Or maybe, if you have the capacity, you could sample all of the cases. That's even better. And generally with these studies, incident cases are preferred over prevalent cases. And then similarly with controls, controls should be similar to the group of cases. They should be selected from the same population. And that should help mitigate confounding of the relationship between exposure and outcome. Okay. So now we are on to a cross-sectional survey. And essentially, a cross-sectional survey is a snapshot in a specific moment of time of typically prevalence in a specific population or a community. It can be useful for really common health outcomes. And yeah, it's very quick, it's very convenient. Cross-sectional surveys are often the backbone of most health surveillance systems. And you can look at more than one disease, more than one exposure or risk factor. Yes, much better for prevalent cases because, again, like with incidence, I guess incident cases can fluctuate for different diseases depending on time of year. Like certain diseases like flu are more common in the fall and the winter. And so it's much better for assessing prevalence of diseases that are more longer term in duration. So yeah, that's a limitation of a cross-sectional study. So now I'll take a moment. We've gone through a few study designs, and with any of these study designs, you want to generate some sort of summary measure for perhaps the relationship between your health outcome and your exposure. Like I'd mentioned before, cohort studies, they often can be quite expensive, and they take a lot of time to collect data, but they also can be really useful in assessing kind of the difference in the risk of developing disease between exposed and unexposed groups. So when you have a cohort study, you can calculate the relative risk of disease, which is the risk of disease in exposed groups versus unexposed groups. And that's due to the study design. You take individuals and you watch and you wait for them to develop your health outcome or your disease of interest. You're not able to calculate relative risk for every single study design. So for something like a case control study or a cross-sectional, well, actually just a case control study, you would calculate an odds ratio. Because again, those are studies where you're sampling based off of somebody having a health outcome and then seeing if they have an exposure. So instead of a relative risk, you can calculate an odds ratio, which is the odds of having a certain exposure given a disease. And I know the terminology is a bit tricky there, but we'll reiterate this a few times. And it's generally easier to conduct a case control study than it is a cohort study. And so with a rare condition, a condition with very low prevalence, oftentimes the odds ratio, so the odds of exposure given disease, can approximate the relative risk, which is the risk of disease given exposure. So we can use odds ratios from case control studies to approximate relative risk and really get at the core question that we're interested in, which is what is the risk of disease given exposure? Yeah, so I think a lot of this is what I've just stated. It's an odds ratio is a probability statement about the association between a risk factor and a disease. And it's the odds of exposure in diseased or people with a disease versus the odds of exposure in people who don't have a disease. So if your odds ratio is greater than 1, you may determine that your exposure is associated with having the disease. Whereas if it is less than 1, your exposure may be protective against having the disease. And then the statement that is in bold at the very bottom is just the most common interpretation of an odds ratio. So the odds of having a disease, having been exposed, were X times the odds of having the disease having not been exposed. And yeah, this is the way that you would calculate an odds ratio if you have a 2x2 table from a study where you have the counts of cases and controls, and also the number of people who are exposed to your exposure of interest. So that is how you would work out the math. But if people have more specific questions on the math of this, we can go over it probably towards the end or in a Q&A session. Okay, so we are getting down to, I think, our last few study designs to review for this lecture. Now we're discussing an interventional trial or a randomized control trial, which is one in which the researchers will assign subjects to either receive an intervention or not receive the intervention, be in the control group. And you would follow these individuals longitudinally over time to see if they develop a particular health outcome. So it's great for really common health outcomes in your population. And an RCT is the gold standard for establishing causality between an exposure and a disease. So to break down the terms for a randomized control trial, an RCT is randomized in which patients are randomly assigned into treatment group. And the randomization is key because randomization implies that there's no other factor that is different between the intervention group and the control group, other than just like chance, right? And that helps mitigate confounding and kind of establish a basis for a causal relationship between the intervention and the health outcome. And RCT is controlled in that there's a control group, which is either being given a placebo, like a sugar pill, or just the standard of care, so that they're not receiving the intervention. And an RCT is also double-blind, which means that neither the patients nor the investigators know what treatments the patient is receiving. So that's important because if the patients know that they're in a particular group, that may impact their perception of their health status. And it also may, if the clinicians know, it may impact the way that the patients are treated. So it's just useful for neither group to be aware of who's given what. So the pros and cons of an RCT, it's really great for establishing causality and mitigating confounding, which we discussed. You know that your exposure or your intervention is going to precede your outcome because you're following these individuals after you've given them the intervention to see if they develop the disease. And I think the cons can be RCTs are very expensive, and obviously it may not always be ethical to randomly assign people to different intervention groups, say if there are certain risks associated with an intervention, or even if you know that like the intervention could hold a lot of benefit to the population of interest. In that case, like withholding it from them for an unnecessarily long period of time is not very ethical. So it really can only be used in very specific use cases. And yeah, they can struggle with issues of generalizability to the larger population as well. So here I am showing you an example of a randomized controlled trial. And this is very relevant to my work in that I work on modeling the impact of malaria vaccinations on like malaria burden in a few different countries in sub-Saharan Africa. And as I'm sure many clinicians in the audience know in much more detail than myself, there is a relatively new vaccine, R21, that is being introduced to like areas of moderate to high malaria transmission in sub-Saharan Africa. And then because this vaccine is new, efficacy trials are needed to assess how protective the vaccine is against malaria, for how long, as well as any other safety considerations. So you can see just quickly based off of the backgrounds and the methods that this is a double-blind randomized trial where children are randomly assigned to either receive the R21 vaccine or the control. And so they're assessed over a period of time. They're followed up to see if there are differences in malaria incidence between these groups. And then the research investigators will compare the difference in incidence rates between the groups to assess vaccine efficacy and just how protective this vaccine is against malaria in this group of children. So now we're down to the last study that we'll review for today, which is a systematic review. A systematic review is a study of studies. So it is a study design in which you have a protocol. You search for studies on your topic of interest. Say you're interested in smoking and lung cancer. You'll do a structured search, typically these days on the internet, on PubMed, and you will review all of the studies published over a certain period of time on this subject, and just kind of evaluate the state of the literature on this subject and what the general finding can be from these studies. And I have a visual of that on this slide where you decide what you're interested in. You'll search for these studies on PubMed or Medline, and you'll have very clear inclusion or exclusion criteria. Say you're only interested in studies published after 2017, or you exclude studies on a group of people that are not representative of the larger population, like maybe occupational studies or things like that. So you'll screen these studies based off of these criteria, and then you'll extract the data from each study on, say in this example, the relationship between lung cancer and smoking. So you'll extract all of that data, and you'll kind of see where the differences lie. And then you'll publish that study of studies or study of the available evidence. And here's just a figure that I took from a random systematic review. And here on the right, you have this plot plotting the risk ratios for a bunch of different studies and seeing kind of how different they are from study to study, and the population sizes for each study. And so this is a common sort of plot that you'll see in a systematic review, kind of where you've reviewed all these studies and then you've extracted the data and you've said, this is what every study that we've reviewed says on this subject. Yeah, and so you extract relevant data and then report on it. And a meta-analysis is, I guess, related to a systematic review, in that you may extract data from published literature on the metric you're interested in analyzing, but you may also utilize additional quantitative methods to make the data from these heterogeneous data sources more comparable. And so, yeah, adjustment methods that you can use in biostatistics to make these sources more comparable. Meta-analyses, in a lot of ways, they're like the foundation of a lot of disease modeling, where you're intaking data from heterogeneous data sources, trying to make them comparable. And then your model outputs are essentially just like a measure of what you think is truly happening in your population of interest. Yeah, so that's a high level, but I think we could talk about meta-analyses for much longer, maybe in a different course or a different seminar. And here's just a flowchart of how you might go about choosing the study design for a study that you would like to conduct. So first you would check and see, oh, is there a gap in the evidence that already exists? Develop a research question, a hypothesis that you want to test, that ideally like hasn't been tested before, maybe not in your setting or context. And then from there, kind of decide if you want to go down the experimental path and assign exposure to different groups of people. And that's where these trials are. Or you could go down the observational path. And as we've discussed in the lecture, there are different study designs that are more beneficial for different diseases, like say a disease that is more prevalent. A cohort design may be more useful. And obviously it's much more complicated than this. You may, a study design choice usually comes based on factors like budget, the duration of disease, what is typically done in EPI with regards to the disease of interest. But yeah, this is just like a high level chart of how you might go about choosing your study design. So I think that we've gone through about everything. I zipped through everything fairly quickly, but I would welcome any questions, either about the material that was presented or really anything else. And I will try my best to answer, but thank you all for listening so diligently over the past 40 minutes or so.
Okay. Thank you very much, LIDIYA. That was a very interesting and engaging presentation. So you've taken us through several study designs. You've highlighted their strengths and limitations, and you've also provided practical examples and case studies, which I believe have provided us with a deeper understanding of the subject matter. And I'm sure it has left the audience inspired to explore this field further. So thank you very much for that. So having said that, we'll directly proceed to the Post CME quiz. So I'll shortly share the link below. Okay, so I'm pasting the link to the form directly in the chat box. So there are a total of 7 questions. So just to reiterate, you must answer all questions to receive the CEU points. A score of 50% or higher is required to earn 2 CEU points. So please take your time and attempt the quiz carefully. So I've pasted the link below. You can directly attempt the quizzes. You have 10 minutes. Okay, so time is up. We're no longer accepting responses. 70 of you have attempted the quiz. So thank you very much. So if you've been, if you fulfill the aforementioned criteria, you'll receive your certificates in a matter of 1 to 2 weeks. So we ask that you wait patiently. So having said that, we'll directly proceed to the Q&A session.
Great. I'm just looking at the Q&A. I will apologize. I do think that there are a few questions that I don't know the answer to, and so I don't want to lead you astray, but if there are other epidemiologists on the call, feel free to jump in. So specifically the question about non-inferiority trials. Yeah, I'm not familiar with that kind of trial, so I'm not sure if we would only use those in experimental study designs. And then I'm also not sure what an umbrella study is. So yeah, I apologize. If you email me after, maybe I can try to investigate just maybe with a little bit more information. And yeah, also the question about the rule or criteria for stopping randomized control trials after the time in which or if we see that there's no statistically significant results. My inclination is that there isn't a standard rule, and that the length of follow-up would be fixed in the research proposal prior to the trial being conducted, and ideally you would probably just carry it out until the time that you had expected it to be complete. But you know, I can't say for certain in that I'm not involved in the day-to-day administration of an RCT. So if other people have comments on those 3 questions, feel free to jump in. The first 2 questions I can take. The question of what is, I think what you mean here is what is the difference between a cohort study and a case control study? And that's quite similar to the next question of the difference between a case control study and a retrospective cohort design. So essentially the difference between a cohort study and a case control study is the key difference lies in the sampling method. So with a case control study, you are specifically sampling based on the health outcome. So you're sampling a number of cases of disease, as well as a number of people who don't have the disease that you're interested in studying. Whereas with a cohort study, you're not sampling based off of the health outcome. With a prospective cohort study, you would just take individuals, assess exposure at the beginning, and then just wait and see if they develop a health outcome. Whereas with a retrospective cohort study, you're looking backwards in time at like health outcome and exposure. So in that case, it is similar to a case control, but because you're not sampling explicitly based off of the health outcome of interest, it's a slightly different design. And you're still, with a cohort study, you're looking backwards, but the exposure still precedes the development of the health outcome. So it's slightly different in sampling method, though I think specifically like a case control study design and a retrospective cohort study, they are often confused, and the wrong summary measure can be calculated because they're similar, so it would be easy to confuse. So I hope that clarifies, but if it doesn't, feel free to jump in and we can get into that in more detail. So I think those were all of the questions, but if there are others that come up, yeah, just jump in now.
So, thank you very much. So I think all of the questions have been addressed in an appropriate manner. So we are now at the final session. So I'll directly share my screen with the Post CME quiz, and we will attempt them together. Okay, so these were the Post CME questions. So the first question reads: healthcare officials are curious about what factors contributed to the outbreak of Salmonella in Sacramento. They believe the outbreak might be due to a questionable shipment of eggs at the local grocery store. These officials randomly sample a group of patients newly infected with Salmonella, as well as a group of people who do not have Salmonella. They ask all subjects whether they have eaten eggs from the grocery store recently, comparing egg consumption between infected individuals and non-infected individuals. So the next three consecutive questions are based on this case. So the first question reads: what kind of study design is this? So A reads case report, B is cross-sectional study, C is case control study, and D is randomized control study, right? Randomized control trial.
So with this question, I know the wording sounds confusing, but it's a case control study. So you are sampling based off of the health outcome. So you're sampling both people who developed Salmonella and people who have not developed Salmonella, and then you're checking their exposure to the eggs. So that's a case control study.
Thank you. The second question reads: the healthcare officials collect data from their sample on egg consumption over the outbreak period. What would be an appropriate measure of the relationship between egg consumption and Salmonella in this sample? So A reads odds ratio, B is relative risk, C is risk difference, and D reads incidence.
Yeah, so with this, it's A, and it's an odds ratio because an odds ratio is an appropriate summary measure for a case control study. It's the odds of exposure, in this case, exposure to egg consumption, given that you have Salmonella. And then I see that follow-up question of question 1, could it be a retrospective cohort study? So in this case, it couldn't be, though I understand why you would think that because they're quite similar, like a retrospective cohort and a case control, but it's specifically that like sampling method that is important here. So because we're sampling based off of whether individuals have Salmonella, then that's why it's a case control and not a retrospective cohort. And then similarly, that follow-up of why not relative risk, because it's a case control study as well, an odds ratio is the appropriate measure of like association between exposure and outcome for that study design.
Thank you. The third question reads: health officials would like to know whether the faulty egg shipment caused the Salmonella outbreak. So based on their data, can they answer this question? A reads yes, if egg consumption is higher in infected people than non-infected people. B reads yes, because exposure precedes outcome. C reads no, because there may be some other difference between infected people and non-infected people. And the last choice, D reads no, because people can recover from Salmonella, which may impact results.
Oh, okay, yep. Here, though, I think my service is a bit troubled. It's C here because while, you know, say you look at the results and there's a difference in exposure between the Salmonella cases and not, you might think that the egg shipment is causing the outbreak, but we can't say for sure with a case control study design. It provides a measure of the association between the exposure and the outcome, but it doesn't like provide. Yeah, so sorry, my internet disconnected. Were we on question 3?
Yes, we were.
So yes, the answer here is C because this is a case control study, we may have evidence of an association between the eggs and Salmonella in this sample, but we can't determine or we can't firmly establish causality between those two things, just simply based off of the study design. There may be some other like factor that is different between the infected cases and the uninfected cases that could have caused the outbreak. And yeah, it could be egg consumption. Clearly, this study provides evidence of an association, but we can't confirm causality.
Thank you. So the next question reads, a sample of Egyptians in Cairo enrolled in a study conducted by the Egyptian Public Health Department over a 20-year. They received medical follow-up twice a year where their blood pressure, weight, and other health conditions are recorded. They are also asked about their diet, alcohol intake, and exposure to smoke. Researchers are curious about how different chronic conditions develop throughout the life course in this group. So the next 4 questions are based on this. So the first question reads, what kind of study design is this? So A reads cross-sectional survey, B is cohort study, C randomized control trial, and D case series.
So in this case, this is a cohort study because you've enrolled the participants from the beginning, you've assessed their exposure, and then you're following them over a period of time to see what health outcomes develop. And then again, I'm seeing the question in the chat of what other factors or how can we confirm the association? Well, I suppose with regards to question 3, I think the gold standard for confirming the causal relationship, because I think the case control study provides evidence of an association. The gold standard for a causal relationship is a randomized control trial, because if you randomize exposure to eggs, say in that case, then the randomization implies that there's no other difference between the cases and the people who aren't cases, other than the random assignment. And so as a result of that, you can confirm a causal relationship. So that would be the way to establish that. But otherwise, based off the information we have, we don't know if another factor could have contributed to the salmonella outbreak that also could be related to egg consumption. So it's possible that there's a confounding variable there.
Thank you. The second follow-up question reads, the enrolled individuals are enrolled, then followed over the 20-year period. So this is a blank study. So A reads prospective study, B retrospective study, C experimental study, and D all of the above.
So this is a prospective study because you are following the patients like out into the future over this 20-year period.
Thank you. So the 6th question reads, the researchers noticed that participants who consume more sugar in their diet develop type 2 diabetes more frequently than participants who consume less sugar. What would be an appropriate summary measure of the relationship between type 2 diabetes and sugar consumption? So A reads odds ratio, B relative risk, C R squared, and D type 2 diabetes prevalence.
So this would be relative risk, because relative risk is the appropriate summary measure for the relationship between exposure and outcome for a cohort study.
Thank you. So the last question reads, is this an observational or interventional study? So A reads interventional because the researchers are providing medical care to the participants regularly. B, interventional because the participants receive medical advice by the research staff. C, observational because the researchers are not assigning participants to an exposure group. D, observational because the participants do not know the aims of the study. And E, neither or none.
So this is, it would be C, because the researchers aren't assigning the participants to a particular exposure group. They're just assessing what their level of exposure and then also their health outcome.
So thank you very much. So this is the entire quiz. So we're joined by Dr. Henok today. So Dr. Henok, if you have closing remarks, you can continue.
Perfect. Thank you, Dr. Tadal. And is LIDIYA here still?
Yes, I am.
Hi, LIDIYA. This is a big thank you from me and the rest of the team. And just to say to everyone who's attending that Lydia has been with us from the very beginning, reviewing all those submissions from Addis Ababa University as well as St. Paul. And I want to make a remark about the delayed marks for the St. Paul submission. I'll do that later on. But Lydia is part of us. She's part of the team. And I hope you've all enjoyed and learned a lot from today's session. Thank you so much, Lydia. Much, much appreciated.
No problem. Thank you, everybody, for listening and participating.
How did you enjoy it? How were the questions and the engagement from the audience, if I may ask?
Yes, it was great. Everybody was very responsive. And yeah, it was very nice to be in this setting and to contribute in some way.
Perfect. Thank you, Lydia. Thank you so much once more. And was it Dr. Tadel who's been so eloquently and efficiently managing and moderating the session?
Yes, yes.
Can you hear us, Dr. Tadel?
Yes, I can hear you, Doctor.
Perfect. Thank you. Thank you, Dr. Tadel. I was following up. I had internet connection issues throughout, but it looked, thank you so much. That was so expertly done. We hugely appreciate your inputs for today's session as well. So thank you very much.
My pleasure, Doctor.
Thank you, Dr. Tadel. Thank you, the rest of the team. I know Ayman and everyone else who's been working so hard to make this event a reality is also on this call. So thank you so much, everyone. This is the official start of our seminar series. I expect that some of you who've taken part in the Addis Ababa University research protocol competition would be here. If you are here with us, hello to you all. I'm really delighted that you could be here. This is only the start. There will be more sessions going forward. I see a hello, so I'm seeing that they are here. Really delighted that you can be here with us. And yeah, so this is we're really delighted to kick off our seminar series. There's more coming up, so we'll continue with all that. I might switch to Amharic. Is that okay?
Yes, you can, Doctor.
ስለዚህ በጣም እናመሰግናለን ሁላችሁንም። በጣም እንግዲህ ያው ከሀሳብ የጀመረ ነገር ነው ይሄ። ብዙ ባለሙያዎችን ያሉ ኢንጌጅ ያደረግን እንቀጥላለን በተለያየ ሜቶዶሎጂ ሪሌትድ ቶፒኮች ላይ። ስለዚህ በዛ መልክ እንቀጥላለን ማለት ነው። ይሄ መጀመሪያችን ነው። በጣም በተሳካ ሁኔታ ጀምረናል። ኦዲየንሱም እስከ 80 ደርሶ ነበር እስከማየው ድረስ። so this is all really fantastic. ግን በዚህ አጋጣሚ የሴንት ፖል ተማሪዎች ሰብሚት ያደረጋቸው ሪሰርች ፔፐሮች ሪቪው ተደርገው አልቀዋል። አሁን ኳሊቲ አፕሬዝ እያደረግን ነው፣ ሞዴሬት እያደረግን ነው። የተለያዩ ችግሮች ገጥመውን ነው የዘገየ ነው። ለዛ በጣም ይቅርታ እንጠይቃለን። ግን ኦልሬዲ በሚቀጥለው ሳምንትና 2 ሳምንት ውስጥ አናውንስ እናደርጋለን ሪዛልቱን። ሴሽንም ይኖረናል፣ የፊድባክ ሴሽን የምንማርበት ሴሽንም ይኖረናል። ለሁሉም ተዘጋጅተናል። ትንሽ የሴንት ፖል ከአዲስ አበባ ዩኒቨርሲቲ ካስገቡ በኋላ ስለገባ ብዙ ሪቪወሮቻችን ወደ ተለያየ ስራ ሄዱ። እነሱን አሰባስቦ ሪቪው አምጥቶ በተጣራ መልኩ አድርጎ ከዛ በኋላ ደግሞ ሞዴሬት የምናደርገው ሰዎች እኔም አልኩት ማይ ሃንድስ አፕ። በጣም ኮምፕሊኬትድ የሆነ ስራ ውስጥ ነበርኩ ፎር ዘ ላስት 2-3 months እና በስራ ጫና አማካኝነት ነው በጊዜ ባለማድረሳችን ሁላችንም በጣም ተሰምቶናል። ያንን እናስተካክላለን ወደፊት። ያው አዲስ ጅማሮ ነው የጀመርነው። ትምህርት እየተማርንበት እየሄድን ነው። ግን በጥራት ሙሉ ፊድባክ የምታገኙበት መልክ ተመቻችቷል። ያም ደግሞ በጥራት መልኩ እናንተ ጋር ሲደርስ ሞዴሬትድ በሆነ መልኩ ኳሊቲውን በጠበቀ መልኩ ለማድረግ ያው እዛ ላይ ኮምፕሮማይዝ ላለማድረግ ነው የቆየነው። በጣም ኢንትረስቲንግ የሆኑ ፔፐሮች ናቸው የገቡት። አንብበናል፣ አይተናል። ኮመን የሆኑትን ፊድባኮች ደግሞ ሰብስበን አንድ ላይ ዲስከስ እናደርጋለን። ኦኬ ስለዚህ እሱን ጠብቁን። ኢሚነንትሊ በሚቀጥሉት ሳምንትና 2 ሳምንት ውስጥ ሪዛልቱን አናውንስ እናደርጋለን። ሴሽን እንደዚህ ሆልድ እናደርግና ከእናንተ ከመምህሮቻችሁን ጋር ከእናንተም ጋር አሸናፊዎቹን አናውንስ እናደርጋለን። አብረን ደግሞ ሁሉም ሰው ሊማርባቸው የሚገቡ ነገሮችን አንጥረን አውጥተን ዲስከስ እንወያያለን ማለት ነው። ስለዚህ ይሄንን ነው ሼር ማድረግ የምፈልገው። ስታቲስቲካል ሞዴሊንግ ላይ ሶፋር አሬንጅ አላደረግንም፣ ግን የሚከብድ ነገር አይደለም። እሱ ሰፊ ኢንትረስት ካለ እሱን አሬንጅ ለማድረግ እንሞክራለን ጎይንግ ፎርዋርድ። በተለይ አንዱ የኛ ፓነል ሜምበር የስታቲስቲካል ሞዴለር ነው እና እሱን መጠየቅ እንችላለን። እሱን ሀሳብ እናሰባስባለን። ይሄንን መዝግበን ያንን ሴሽን አሬንጅ ለማድረግ እንሞክራለን። በተረፈ ይሄ ነው ከኔ በኩል ያለው። ዶክተር ታደል what about operational study? Do you mean operationalization of study? Right? Or do you mean implementation research? What do you mean by operational study? Implementation research. Implementation research, it's a thing on its own. We have one on qualitative research. Exhaust address ለማድረግ እንሞክራለን። ብዙ ራሱን የቻለ ሴሽን አላዘጋጀንም፣ ግን ኳሊቲ ኢምፕሩቭመንት ላይ አንድ ራሱን የቻለ ሴሽን ኦልሬዲ ፕላን ተደርጓል። እዛ ውስጥ የሚካተቱ ነገሮች ካሉ አብረን ለማካተት እንሞክራለን እዛ ጋር። በተረፈ ደግሞ እንደዚህ እየተወያየን ሌሎች ፕላኖች አሉ። ይሄኛው አመት በእኛ በኩል ያሉትን ሴሚናሮች ቶሎ ለመጀመር ነው። ከዚህ ቀጥሎ ያሉን ፕላኖች ደግሞ አገር ውስጥም ያሉ ሪሶርሶችን፣ ኤክስፐርቶችን፣ የእናንተን አስተማሪዎች ኢንጌጅ የምናደርግበት እናንተም ኢንትረስትድ የሆናችሁባቸውን ስፒከሮች ኖሚኔት የምታደርጉበትን መንገድ እናፈላልጋለን። በዛ መልኩ እንቀጥላለን። ኢምፕሊሜንቴሽን ሪሰርች is quite a niche specialized የሆነ ኤሪያ ነው። እኔ የተወሰነ ልምድ አለኝ፣ የተወሰነ ንባብ አለኝ። ግን አብረን እስቲ ብዙ ኢንትረስት ካለ ፖል እናደርግና አድርገን የኳሊቴቲቭ ሪሰርች የሚሰጥ ቀን ኪ አስፔክቶችን በተለይ ወይ ደግሞ በኪው&ኤ የእናንተን ጥያቄዎች ለመመለስ እንሞክራለን። So if you have any questions on implementation research, come to the qualitative research session. እዛ ላይ አብረን ዲስከስ እናደርጋለን። በተረፈ I believe የኔ ሴሽን ነው ቀጥሎ የሚመጣው። እሱም ላይ እንገናኛለን። I'm trying to organize something around critical review of research papers. እዛ ላይ ዲስከስ እናደርጋለን። በተረፈ በእኔ በኩል በጣም ደስ ብሎኛል በዚህ መልኩ ስለጀመርን። ድጋሜ ሊዲያን በጣም እናመሰግናለን፣ ሁላችሁንም እዚህ ስለመጣችሁ። በዚህ መልኩ እንቀጥላለን። ሴንት ፖሎች በቅርቡ ኮሚኒኬት እናደርጋለን ሁላችሁንም። ከወዲሁ ደግሞ በቲሙ ስም በራሴ ስም ይቅርታ ጠይቃለሁ ስለዘገየን። እናመሰግናለን። ባክ ቱ ዶክተር ታደል።
Thank you very much, Dr. Enoch. We're at the end of our webinar. So thank you, everyone. Thank you, Lydia. That was a very interesting session. We're also joined by Dr. Abil from Ethiopian Society of Internal Medicine. So we're glad to have you with us. Thank you, everyone. Dr. Eden, as well as Dr. Ayman. So in order to get news or updates about our upcoming activities, please join our social media. The links have been provided. And in case you haven't registered, we have another CME coming up tomorrow on the topic of urinary tract stone disease. So please sign up and join us if you haven't already. So thank you, everyone. Thank you for joining us. Good night.
Thank you. አመሰግናለን።